Acetaminophen paracetamol. This is the world's most popular painkiller, Tylenol, Panadol, whatever you call it. And here's the crazy part, scientists still don't fully understand how it works. What we do know is that it messes with an enzyme in your brain that produces pain-amplifying chemicals called prostaglandins. Fewer prostaglandins means your brain needs a louder pain signal before it even notices. It handles headaches, fevers, and mild aches beautifully, but it does absolutely nothing for swelling or inflammation. Now here's where it gets scary. Acetaminophen is the #1 cause of acute liver failure in many countries, not because it's dangerous at normal doses, but because it's hiding in everything. Cold medicines, sleep aids, prescription painkillers. People accidentally stack doses without realizing it. Add alcohol to the mix, and even normal doses can trash your liver. The maximum is technically 4,000 milligrams a day, but many doctors now say stay under 3,000. Despite all that, when used correctly, it's one of the safest options out there. No stomach irritation, no blood thinning, safe for pregnant women, kids, and elderly patients. Just read your labels. Aspirin. Aspirin has been around since 1897 and it's basically a Swiss Army knife in tablet form. Painkiller, anti-inflammatory, fever reducer, and blood thinner, all in one. It permanently disables an enzyme called COX, which stops your body from making the chemicals that cause pain, swelling, and blood clots. That blood thinning effect is why millions of people pop a baby aspirin every day to prevent heart attacks. One dose affects your platelets for their entire 10-day lifespan. But that same power comes with a cost. Aspirin eats away at your stomach lining, which can lead to ulcers and internal bleeding over time. And there's one absolute rule: never give aspirin to kids or teenagers with a viral illness. There's a rare but potentially fatal condition called Ray's syndrome that's directly linked to aspirin use in young people fighting infections like flu or chickenpox. Ibuprofen, Advil, Motrin, Nurofen. Whatever brand you grab, ibuprofen is probably the world's favorite anti-inflammatory painkiller. Like aspirin, it blocks COX enzymes and slashes prostaglandin production, killing pain, reducing swelling, and lowering fever simultaneously. Unlike aspirin, though, its effects are reversible. Once it wears off, everything goes back to normal. That's why it doesn't thin your blood the same way. The catch? It can wreck your stomach with long-term use. It can mess with your kidneys if you're dehydrated, and at high doses over long periods, it slightly raises your risk of heart attack and stroke. Also, and this is one most people don't know, if you take ibuprofen at the same time as your daily baby aspirin, the ibuprofen can actually block the aspirin from protecting your heart. Take the aspirin first, wait 30 minutes, then take ibuprofen. Naproxen. Naproxen, you know it as Aleve, works almost identically to ibuprofen. Same mechanism, same benefits. So why does it exist? One word: duration. Naproxen lasts 12 to 17 hours in your body, compared to ibuprofen's measly 2 to 4. That means 2 pills a day instead of popping one every few hours. For anyone dealing with all-day arthritis pain, that's a game changer. There's also some evidence that naproxen is slightly kinder to your heart than other NSAIDs, which is why doctors sometimes prefer it for patients with cardiovascular risk factors. The trade-off is that if you do get a side effect, it sticks around longer because the drug takes longer to leave your system. Diclofenac. Diclofenac is one of the most powerful NSAIDs you can get, and it comes in a form most people don't expect: a gel you rub on your skin. Voltaren gel delivers the drug straight into your aching knee or sore joint while keeping blood levels at just 5 to 10% of what you'd get from swallowing a pill. That means real anti-inflammatory action right where you need it, with way fewer side effects on your stomach, kidneys, and heart. The oral version is a different story. Multiple studies have flagged oral diclofenac as carrying roughly 40% higher cardiovascular risk compared to taking no NSAID at all. That's why many doctors will reach for naproxen or ibuprofen first and save oral diclofenac as a backup. Celecoxib or Celebrex. Here's the idea behind celecoxib. Traditional NSAIDs block two enzymes: COX-1, which protects your stomach, and COX-2, which drives inflammation. What if you could block only COX-2 and leave the stomach alone? That's exactly what celecoxib does, and it works. Significantly fewer ulcers and GI bleeds compared to old-school NSAIDs. But this drug class has a dark history. In 2004, a similar drug called Vioxx was yanked off shelves after it was found to cause heart attacks and strokes. Celecoxib survived because later research showed its heart risk was roughly equal to ibuprofen and naproxen at moderate doses. But it's still prescribed cautiously, especially for anyone with heart problems. Ketorolac or Toradol. If NSAIDs had a heavyweight champion, Ketorolac would be wearing the belt. This is the painkiller emergency rooms reach for when you come in screaming from kidney stones or post-surgical agony. 30 milligrams of injectable ketorolac has gone head-to-head with morphine in studies and matched it without any of the sedation, breathing problems, or addiction risk. The catch is brutal though, you cannot use it for more than 5 days. Ketorolac has several times the GI bleeding risk of other NSAIDs, and it hammers your kidneys. It's a short-term weapon, nothing more. But when you need a non-opioid option for serious pain, nothing else in the NSAID family comes close. Lidocaine. Lidocaine is a local anesthetic. It physically blocks nerves from sending pain signals by shutting down their sodium channels. Your dentist uses it before drilling. Sunburn sprays contain it, but for chronic pain, it comes as patches and creams that numb the skin and the nerves underneath. The Lidoderm patch, 5% lidocaine, is a go-to treatment for the nerve pain that lingers after shingles. Stick it on for 12 hours, peel it off for 12 hours, repeat. Because almost none of the drug enters your bloodstream, side effects are basically limited to mild skin irritation. For pain close to the surface, it's one of the safest options available. Capsaicin. This is literally the chemical that makes chili peppers burn your mouth. And someone figured out it could treat pain. Here's how. When you first apply capsaicin cream, it activates pain receptors and yes, it burns. But keep applying it for a few days and something wild happens. The nerve fibers run out of a chemical called substance P, which they need to send pain signals. No substance P, no pain message. The nerves basically exhaust themselves. There's even a prescription patch called Cutenza that contains 8% capsaicin, about 100 times stronger than the drugstore cream. A healthcare professional applies it for 30 to 60 minutes, and that single application can provide pain relief for up to 3 months. The initial burn is intense, but for people with chronic nerve pain who push through it, the results can be remarkable. Menthol and methyl salicylate. Bengay, Icy Hot, Tiger Balm, BioFreeze, these are all based on the same trick. Menthol activates cold receptors in your skin, methyl salicylate activates warm receptors. Together they create that classic icy then hot sensation. None of this actually changes your tissue temperature or reduces inflammation. It's pure distraction. The flood of cooling and warming signals traveling along your nerves can partially drown out pain signals trying to reach your brain. They're temporary, 30 minutes to a few hours of relief. And they're generally very safe. One weird exception though, methyl salicylate is related to aspirin and in extreme cases of overuse, slathering huge amounts over large body areas, enough can absorb through the skin to cause toxicity. There have been actual deaths from this, so don't go overboard. Codeine. Codeine is the mildest opioid, and here's its dirty secret. It barely works on its own. Your liver has to convert it into morphine using an enzyme called CYP2D6, and that's where the genetic lottery kicks in. About 5 to 10% of people are poor metabolizers who barely convert any codeine, so the drug does almost nothing for them. On the flip side, 1 to 2% are ultra-rapid metabolizers who convert too much too fast, flooding their bodies with morphine from a standard dose. That ultra-rapid metabolism issue has actually killed children. Several pediatric deaths have been linked to codeine, which is why many countries have now restricted or outright banned its use in kids. You'll usually find codeine combined with acetaminophen, like Tylenol No. 3, for moderate pain, or in cough syrups for its ability to suppress the cough reflex. Tramadol? Tramadol plays both sides. It's a weak opioid, loosely binding to the same receptors as morphine, but it also acts like an antidepressant, boosting serotonin and norepinephrine levels. This dual mechanism gives it a unique pain profile, especially for conditions that have a nerve pain component. When tramadol first came out, everyone thought it was basically harmless. It wasn't even classified as a controlled substance. That turned out to be spectacularly wrong. Tramadol absolutely causes dependence and addiction, and it brings its own special dangers. It can trigger seizures, and if you combine it with antidepressants like SSRIs, you risk serotonin syndrome, a potentially fatal overload of serotonin causing dangerously high body temperature, muscle rigidity, and rapid heart rate. Hydrocodone. This is the most prescribed opioid in America. Vicodin, Norco, Lortab, all hydrocodone mixed with acetaminophen. It binds to opioid receptors in your brain, mimics your natural endorphins, dulls pain, and, here's the problem, creates euphoria. That feel-good hit is exactly why opioids are so addictive. The acetaminophen combo is a double-edged sword. It boosts the pain-killing effect, but it also puts a hard ceiling on how much you can safely take. Exceed the acetaminophen limit, and you're looking at liver failure. This combination sends thousands of people to the emergency room every year. In 2014, the FDA moved all hydrocodone products to Schedule II, the most restricted category, acknowledging what the streets already knew: this stuff is dangerously addictive. Oxycodone. A step up from hydrocodone and roughly 1.5 times stronger than morphine. You know it as OxyContin, Percocet, or roxicodone, and OxyContin might be the most infamous medication in pharmaceutical history. When it launched in 1996, the manufacturer aggressively claimed it had low addiction risk because of its slow-release design. That claim turned out to be catastrophically, historically wrong. People figured out that crushing the tablet defeated the time-release mechanism and delivered the full dose at once, producing an overwhelming high. OxyContin became rocket fuel for the opioid epidemic. The reformulated version from 2010 turns gummy when crushed, making it harder to snort or inject. But by then, countless users had already switched to heroin and illicit fentanyl. Morphine. The original, the gold standard. Every other opioid is literally measured against morphine. Extracted from opium poppies for over 200 years, morphine remains the benchmark for treating severe pain, major surgeries, cancer, crushing injuries, and end-of-life care. It's also the textbook for opioid dangers. Morphine suppresses your brainstem's breathing center. Take too much, or mix it with alcohol or benzodiazepines, and your breathing slows until it stops. That's how most opioid overdoses kill. Constipation is nearly universal and never gets better no matter how long you take it. Your gut has opioid receptors too, and morphine essentially paralyzes your intestines. Physical dependence develops within days. Hydromorphone. Take morphine and make it 5 to 7 times more potent. That's hydromorphone. Hospitals use it when morphine isn't cutting it or when patients can't tolerate morphine's side effects. It causes less itching and less nausea because it releases fewer histamines. But that potency is a landmine. Confuse a hydromorphone dose with a morphine dose, give 5 milligrams of Dilaudid when you meant 5 milligrams of morphine, and you've just delivered the equivalent of 25 to 35 milligrams of morphine. In a patient who isn't opioid tolerant, that mistake can be fatal. Dosing errors with hydromorphone are one of the most well-documented causes of preventable hospital deaths. Fentanyl. 50 to 100 times more potent than morphine, 2 milligrams, an amount that fits on the tip of a pencil, can kill a non-tolerant person. Pharmaceutical fentanyl is a legitimate medical tool. Transdermal patches for chronic cancer pain, lozenges for breakthrough pain, IV drips for surgical anesthesia. The patch alone is a brilliant piece of pharmacology, slowly releasing medication through your skin over 72 hours. But illicitly manufactured fentanyl has become the deadliest drug crisis in modern history. Cooked in clandestine labs, pressed into counterfeit pills designed to look like oxycodone or Xanax, mixed into heroin and cocaine, it's now the leading cause of overdose death in the United States. Its analog carfentanil is 100 times stronger than fentanyl itself, 10,000 times stronger than morphine. Naloxone, the overdose reversal drug, often needs to be given multiple times for fentanyl because it grips opioid receptors so tightly. Methadone. Methadone lives a double life. It's both a pain medication and an addiction treatment. For pain, it's special because it doesn't just activate opioid receptors, it also blocks NMDA receptors, which are involved in amplifying chronic pain signals. This makes it uniquely effective for neuropathic pain and pain that stopped responding to other opioids. But methadone might be the trickiest opioid to use safely. Its half-life is wildly unpredictable, anywhere from 8 to 59 hours depending on the person, so drug levels can silently build up over days before suddenly becoming toxic. Many methadone deaths happen in the first week of treatment. It also messes with your heart's electrical system, potentially triggering fatal rhythm abnormalities. This is not a take two and call me in the morning drug. Buprenorphine. Imagine an opioid with a built-in safety cap, that's buprenorphine. It's a partial agonist, it activates opioid receptors, but only to about 60 to 70% of maximum no matter how much you take. This ceiling effect means it's far harder to fatally overdose on buprenorphine alone compared to full-strength opioids like morphine or fentanyl. It's also incredibly sticky. It grabs onto opioid receptors and won't let go. If someone on buprenorphine tries to use heroin, they'll feel almost nothing because the buprenorphine is hogging all the receptors. That's why Suboxone, buprenorphine combined with naloxone, has become a cornerstone of opioid addiction treatment. For pain, it comes as patches and cheek-dissolving films.